So, what is diuretics? Diuretics are the substances which increase the rate of urine formation by increasing the urine flow rate. So, that is what the diuretics. What is diuretics? Diuretics are the substances or the agents which increase the rate of urine formation. They increase the rate of urine formation by increasing the urine flow rate, and also they increased excretion of the electrolytes. Now, which electrolytes they excrete from our body? Especially sodium and chloride. Of course, they also excrete other electrolytes, but specially they excrete sodium and chloride ions from our body with the water without affecting protein, vitamin, glucose, or the amino acid reabsorption. So that's what the diuretics. Okay, so what is diuretics? Diuretics are the substances or the agent which increase the rate of urine formation by increasing the urine flow rate, and also they increase the excretion of the electrolyte, especially sodium and chloride, with water from the body without affecting protein, vitamin, glucose, or the amino acid reabsorption. Now, these diuretics they are used in the treatment of the congestive heart failure, nephrotic syndrome, and the chronic liver disease. And also, they are used in the management of the hypertension. They are also used in the treatment of the clinical condition including hyperkalemia, diabetes insipidus, and the acute mountain sickness. Also, they are used in the glaucoma. They are used in the treatment of the glaucoma. The primary target of the diuretics is the kidney. As we know, the diuretics they especially and they are effectively act on the kidney, where they interfere with the reabsorption of the sodium and the other ions from the lumina of nephrons. The nephron is what? It is a functional unit of the kidney. What is nephrons? Nephrons is the functional unit of the kidney. And what is the function of nephron? Nephron generate the urine. Whatever urine is formed, it is done by the nephrons, and nephron is the functional unit of the kidney. So diuretics, the primary target of the diuretics is what? It is the kidney, where it interferes with the reabsorption of the sodium and the other ions. The amount of ions and water which is excreted as urine following the administration of the diuretics, it is determined by many factors including chemical structure of the diuretic, site of action of the agents, the salt intake of patient, and amount of extracellular fluid present. Okay, so whatever the amount of the ions and whatever the amount of water which is excreted as the urine following administration of diuretics. So after administration of diuretics, how much amount of ions, how much amount of water is excreted as the urine, it is determined by various factors, and the factors include chemical structure of the diuretic, site of action of the agents, the salt intake of the patients, and the amount of extracellular fluid present. Okay, now we will see. Now this is what about the introductory part of the diuretic. So in the introductory part, what we studied what is diuretics. So what is diuretics?
Sir, slide is not visible.
Slide is not visible. Wait. Yes, it is visible. Everyone, please, whether the slide is visible or not.
Yes, sir. Yes.
Yeah, it is visible because yes, it is visible. Check out properly.
सर प्रेझेंट वाली शीट दिली आहे.
हा मग तेच आहे, हेच आहे जे मी सांगतोय ते हेच आहे जे मी एक्सप्लेन करतोय ना ते पुढच्या स्लाइड मध्ये आहे मेन्शन केलेलं. ओके, सो व्हॉट इज डायरेटिक्स? Diuretics are the substances which increase the rate of the urine formation. After administration of diuretics, the urine is formed. Now, who is going to form urine? The urine is formed in the nephron. Nephron is what? Nephron is the our the primary factor of the kidney, or the primary function of the kidney, or the functional unit of the kidney, that is a nephron. So what is diuretics? Diuretics are the substances which increase the rate of the urine formation. Once the urine is formed, they also excrete some electrolytes with the water from our body. These diuretics, they are used in the treatment of various diseases like the CHF. Then they are also used in the nephrotic syndrome. They are also used in the chronic liver disease, and also they are used in the management of the hypertension. These diuretics, they are also used in some clinical conditions like hyperkalemia, diabetes, and acute mountain sickness, and also they are used in the treatment of the glaucoma. Now, as we have discussed, the primary target of the diuretics, it is what? It is the kidney, where it interferes with the reabsorption of sodium and also with the other ions from lumina of nephrons. The amount of ions and water which is excreted as urine following administration of diuretics, it is determined by various factors like the chemical structure of diuretic, then its site of action of the agents, the salt intake of patient, and the amount of the extracellular fluid. So by these factors, the amount of ions and how much amount of ions and how much amount of water it is excreted as a urine, it is determined. Now regarding the normal physiology of the urine formation, now there are two important functions of the kidney. Which are the two important functions of the kidney? The first function is to maintain homeostatic balance of the electrolytes and the water. Okay, so there are two functions of the kidney, two important functions of the kidney. Now which are the two important functions? The first important function is to maintain balance of electrolytes and water, and second function is what? That is to excrete water soluble end product of the metabolism. So these are the two important functions of the kidney. Which are the two important functions? The first important function is to maintain balance between electrolytes and the water, and the second function is to excrete water soluble end product of the metabolism. So to accomplish this function, who is going to work? That is the nephrons. Nephron is going to accomplish these two functions. Now in each kidney contain about the 1 million of nephrons. Each kidney contains about 1 million of the nephrons, and they capable of urine formation. Each nephron, there are 1 million nephrons in kidney, and each nephron is capable of the urine formation. These nephrons, they are composed of some components like the glomerulus, and also they are composed of the various tubules like the proximal tubule, loop of Henle, and the distal tubule. They each nephron component, which are what are the component of the each nephron? That is the tubules, loop of Henle, and the distal tubule. So each component of the nephron, they contribute to the normal function of the kidney, and thereby each and every component of the nephron is the target for the different class of the diuretics agent, because each component of the nephron is having some specific activity. So if each component of the nephron is having specific activity, and hence Each component is the target for the different class of the diuretic agent. Now this urine formation, it is begin with the filtration of blood at glomerulus where the filtration of blood takes place, right? Glomerulus is a component where filtration of the blood takes place. Approximately 1200 ml blood, it is flow per minute through kidney. What amount? 1200 ml per blood, 1200 ml blood, it is flow per minute through kidney. So it's a huge amount. From kidney, that 1200 ml blood, it is reaches to the nephron. Then after reaching to nephron, from 1200 ml blood, approximately 20% blood, it enter glomerulus and is filtered into the Bowman capsule. Right, whatever the 1200 ml of blood, whatever the 1200 ml of blood, it is reaches to the nephron. So approximately from that 1200 ml blood, 20% blood enter into the glomerulus and is filtered into the Bowman capsule to form the glomerular filtrate. So whatever the filtrate is formed from the glomerulus, that called as the glomerular filtrate. So how much glomerular filtrate is formed? That is the 20% of the 1200 ml blood. Okay. Now that glomerular filtrate, it is composed of the blood components with the molecular weight less than albumin. The glomerular filtrate rate averages 125 ml per minute in humans, but it can vary in the normal function states. So check out properly how much amount of blood is reaches to the kidney. That is 1200 ml blood, 1200 ml blood, और उसमें से ग्लोमेरुलर फिल्ट्रेट कितना बना? दैट इज अराउंड 125 ml, 125 ml, अप्रोक्सीमेटली 1 to 10%, 1200 ml में से ग्लोमेरुलर फिल्ट्रेट बना. But whatever the 125 ml per minute glomerular filtrate is formed in human, so the amount is vary depending on the normal health of the human beings. Okay. Now the glomerular filtrate which is formed from the glomerulus, it leaves Bowman capsule. Wait, I will show you the diagram of the nephron. Yeah, now this is the diagram of the nephron. This is the figure of the nephron. So if you check, so this is what? This is the Bowman capsule, and in this Bowman capsule, in this the Bowman capsule, the blood is reaches the glomerulus, and in the glomerulus the Bowman capsule is present. So approximately 1200 ml of blood, it reaches to the nephron. So this is the diagram of the nephron. So 1200 ml blood, it reaches to the nephron, and approximately 20% blood, it enter into the glomerulus. So 1200 ml में से approximately 20% blood, it enter into the your glomerulus and is filtered into the Bowman's capsule to form the glomerular filtrate. So whatever the glomerular filtrate is formed, then it passes through the various components of the nephrons like the PST, DLH, TLH, DCT, CD. Okay, approximately 20% of the blood, it enters the glomerulus and is filtered into the Bowman's capsule to form the glomerular filtrate. And whatever the filtrate is formed, that filtrate is having molecular weight less than the albumin. The glomerular filtrate rate averages 125 ml per minute. तो कितना ग्लोमेरुलर फिल्ट्रेट बनता है अपने ब्लड से? तो अराउंड 125 ml पर मिनट इतना ग्लोमेरुलर फिल्ट्रेट बनता रहता है ये Bowman's कैप्सूल में. But the rate is differ depending on the normal health condition of the patient. So the glomerular filtrate, the glomerular filtrate, it leaves Bowman capsule and enter into the PCT, that is the proximal convoluted tubule, which is the component of the nephron. So this glomerular filtrate, it leaves the Bowman capsule and it enters into the PCT, the proximal convoluted tubule, that is the site 1 and the site 2. So this is the portion of the PCT, that is the proximal convoluted tubule. So here the absorption of some ions takes place. Absorption of some ions takes place. So how much of the absorption of the ions takes place? That is 50 to 60% of the sodium, glucose, phosphate, amino acid and bicarbonate reabsorption takes place in this site. Okay, whatever I have mentioned, the glomerular filtrate, it contains specifically the sodium and the chloride ion, but they do not contain only the sodium and chloride ion, they also contain various other small concentration of the ions. So this phase, that is the proximal convoluted tubule, that is the phase start from the S1 to the S2, it absorbs some ions. So which ions they absorb? That is around 50 to 60% sodium, glucose, phosphate, amino acid and bicarbonate reabsorption takes place. Glucose and amino acid, they are completely reabsorbed over here, right? The glucose and the amino acids, they are completely reabsorbed at this site. 80 to 90% phosphate and 80 to 90% bicarbonate reabsorption also takes place at this site. Okay, so किसका किसका एब्जॉर्प्शन होता है ये साइट पे? दैट इज 50 to 60% सोडियम, ग्लूकोज, phosphate, amino acid and bicarbonate reabsorption takes place at this site, at S1 to the S2 site. 50 to 60%, 50 to 60% means what? That is जितना आपका ग्लोमेरुलर फिल्ट्रेट है तो 125 ml per minute, so that is the 100%. So from that 100%, 50 to 60%, from that 100%, 50 to 60% sodium, glucose, phosphate, amino acid and the bicarbonate reabsorption takes place at this PCT site. Okay, so out of these, glucose and the amino acids, they are completely reabsorbed, whereas 80 to 90% phosphate and 80 to 90% bicarbonate reabsorption takes place at this site. Okay, now the reabsorption of sodium and bicarbonate, the reabsorption of the sodium and the bicarbonate, it is facilitated by the enzyme called as the carbonic anhydrase. It is catalyzed by the enzyme called as the carbonic anhydrase. This enzyme is present in this phase, that is in the PCT phase, and this enzyme catalyzes the formation of the carbonic acid from water and the carbon dioxide. This carbonic acid, which is formed from the carbon dioxide and water, okay, the carbonic acid which is formed from the water and the carbon dioxide, it provides hydrogen ions which drive the reabsorption of the sodium bicarbonate. ओके, तो बाइकार्बोनेट का रीअब्जॉर्प्शन कैसे होता है ये उन्होंने बताया. तो कैसे होता है बाइकार्बोनेट का रीअब्जॉर्प्शन? दैट इज कि जो अपना ये पीसीटी फेज है, ये पीसीटी फेज में एक एंजाइम रहता है. द नेम ऑफ द एंजाइम इज कार्बोनिक अनहाइड्रेस. द नेम ऑफ द एंजाइम इज कार्बोनिक अनहाइड्रेस. This enzyme is present in this phase. Now this enzyme catalyzes the formation of carbonic acid from the water and the carbon dioxide. Once the carbonic acid is formed, it provides hydrogen ions and which drives the reabsorption of the sodium bicarbonate in this phase. The chloride ions, they also reabsorbed with the sodium ions. So NaCl reabsorption also takes place at this site. The reabsorption of the electrolytes and water occurs also in this phase. Okay, the reabsorption of electrolytes and water occurs also in this phase. Now regarding the PST phase, that is the proximal straight tubule, that is the S3 phase, proximal straight tubule. Now in this phase किसका reabsorption होता है? Around 65 to 70% water and sodium chloride and calcium ions, and 80 to 90% bicarbonate and phosphate, 100% glucose, amino acid, vitamin and proteins. They are reabsorbed from the glomerular filtrate. Okay, so this is what the reabsorption of these ions takes place at the PST phase. कौन से ions है? So around 65 to 70% water and sodium, chloride and calcium ions, 80 to 90% bicarbonate and phosphate, 100% glucose, amino acid, vitamins and the proteins. So they are reabsorbed from the glomerular filtrate in this PST phase. Then the DLH phase. Now what is the DLH? That is the descending limb of the loop of Henle. Now this descending limb of the loop of Henle, these are impermeable to ions. So ions cannot pass from this descending limb of the loop of Henle. But water can freely move from this luminal fluid. Water can be freely moved from the luminal fluid. So in this phase, the reabsorption of the water takes place and it concentrates the luminal fluid, because the luminal fluid, it is diluted up to the PST phase, but later on the water is get reabsorbed, the water is get reabsorbed, so it make the concentrated luminal fluid. So only ions are present in this phase. Okay, then later on the luminal fluid, it enter into the water impermeable thick ascending limb of the loop of Henle. Okay, what are the luminal fluid which is passed from the DLH, then it reaches to the TALH phase, that is the thick ascending limb of the loop of Henle, where 20 to 25% filtered sodium and chloride absorption takes place. Okay, यहाँ पे किसका absorption होता है? Sodium and chloride, around 20 to 25%. Then sodium and chloride absorption also takes place in the next tubule, that is the early DCT phase. Okay, now this is the DCT. This is the DCT component. That is the distal convoluted tubule. So this is the early phase of the DCT, and this is the later phase of the DCT. So in the early phase of the DCT, also the sodium and chloride absorption takes place. Okay, 20 to 25% sodium and chloride absorption takes place at the TALH, and also the sodium and chloride absorption takes place at the early stage of the DCT. So it contributes to the urinary dilution. Now these two nephron section, which two nephron section? That is the TALH and the early DCT phase. They are called as the cortical diluting segment of the nephron. The TALH section or the TALH component and the early phase of the DCT. So this phase, so this one, okay, so this phase is called as the cortical diluting segment of the nephron. Then later on, after reabsorption of sodium and chloride takes place at the early phase of the DCT, Then later on, the luminal fluid enter into the late DCT phase. So this one, it reaches to the late DCT phase and the CD, that is the collecting duct. Over here, the sodium ion is reabsorbed in exchange of hydrogen and potassium. Okay, so in this phase, the luminal fluid which contain the sodium ions, they are get reabsorbed in the exchange of the hydrogen and the potassium ion. This process is controlled by mineralocorticoids. Example is aldosterone. Reabsorption of 2 to 3% filtered sodium ions also takes place at this phase. Now this sodium, potassium and hydrogen exchange system, it determines the final acidity and potassium content of the urine. Right. So in this phase, that is the late DCT phase and the CD phase, over here the reabsorption of the sodium takes place in the exchange of the hydrogen and potassium. So this sodium, potassium and hydrogen exchange system, it determines the final acidity and the potassium content of the urine. Later on, after all these phases, means the luminal fluid which is passed from all these phases, then later on at the final stage, whatever the luminal fluid is formed in the all this process, it represent approximately 1 to 2% of the original glomerular filtrate. Okay, whatever the luminal fluid is formed at last after passing from all this component, so that luminal fluid contain approximately 1 to 2% of the original glomerular filtrate with more than 98% of the electrolytes and the water. Then later on, urine leaves kidney through uterus and travel to bladder. Over in the bladder, it's stored until the urination remove it from the body. So this is what the reabsorption of the ions takes place at the various phases of the nephron. Now this is all the parts which I have discussed. ये जितने भी स्लाइड्स है ये सब स्लाइड में वही दिया है कि कौन से फेज में किसका रिएब्जॉर्प्शन होता है. मैंने बस आपको समराइज करके बताया. सो जस्ट गो टू ऑल दीज स्लाइड्स. ओके, ये सब स्लाइड में वही बताया कि कौन से जगह पे किसका रिएब्जॉर्प्शन होता है. ओके, बस मैंने आपको एक समराइज करके बताया. फाइन. Now we will come to the next part, that is the normal regulation of the urine formation. How the urine formation is get regulated. So our body it contains several mechanisms. The body contains several mechanisms which regulate the volume and the content of the urine. ठीक है. सो अपने बॉडी में ऐसे बहुत सारे मैकेनिज्म है और वो मैकेनिज्म रेगुलेट करते हैं वॉल्यूम एंड कंटेंट ऑफ यूरिन को. नाउ दिस सिस्टम्स, जितने भी सारे मैकेनिज्म है, जितने भी सारे सिस्टम है जो रेगुलेट करते हैं यूरिन के वॉल्यूम को या फिर यूरिन के कंटेंट को, नाउ दिस सिस्टम आर एक्टिवेटेड बाय चेंजेस इन सोल्यूट और वाटर कंटेंट ऑफ बॉडी, by changes in systemic or the renal BP and other stimuli. ओके, तो जैसे ब्लड प्रेशर आइदर सिस्टेमिक और रेनल ब्लड प्रेशर बढ़ गया या फिर कम हो गया, तो उस टाइम ये जो भी सिस्टम्स रहते हैं, जो अपने बॉडी के अंदर जो भी सिस्टम्स रहते हैं, दैट सिस्टम्स आर गेट एक्टिवेटेड. नाउ एक्टिवेशन ऑफ वन और मोर ऑफ दिस सिस्टम by diuretic drug, it modify the effectiveness of this drug to produce therapeutic response. Now disturbance in the glomerular filtrate rate, the disturbance in the GFR, that is the glomerular filtration rate. एक बार अगर कुछ डिस्टर्बेंस हो गया, अगर कुछ डिस्टर्बेंस हो गया in the glomerular filtration rate, then at that time kidney respond by specialized distal tubular epithelial cells called as the macula densa cells. ठीक है, यानी ग्लोमेरुलर फिल्ट्रेशन रेट में कुछ डिस्टर्बेंस आ गया, कुछ लेस कॉन्सेंट्रेशन में ग्लोमेरुलर फिल्ट्रेट जनरेट हो रहा है, तो उस टाइम मैक्यूला डेंसा सेल्स रहते हैं, वो मैक्यूला डेंसा सेल एक्टिवेट हो जाते हैं. What are the macula densa cells? They are in close contact with the glomerular apparatus of the nephron. जो भी मैक्यूला डेंसा सेल्स रहते हैं, they are present in the close contact with the glomerular apparatus of the nephron, and they detect changes in the rate of urine flow and luminal sodium chloride concentration. What are the macula densa cells? जो भी है, तो मैक्यूला डेंसा सेल्स का काम क्या है? That is, they detect the disturbance in the glomerular filtration rate. वो और क्या डिटेक्ट करते हैं? They also detect the rate of urine flow and also they detect the luminal sodium chloride concentration. तो ऐसा कुछ अगर ग्लोमेरुलर फिल्ट्रेशन रेट जो भी है उसमें अगर कुछ डिस्टर्बेंस हो जाता है, तो कौन सा मैकेनिज्म है या फिर कौन सा सिस्टम है अपने बॉडी में जो एक्टिवेट हो जाता है? दैट इज द मैक्यूला डेंसा सेल्स, वो एक्टिवेट हो जाते हैं. तो व्हाट आर द टू समराइज दिस, कि अपने बॉडी में ऐसे बहुत सारे सिस्टम है, बहुत सारे मैकेनिज्म है कि कुछ भी कहाँ पे भी गड़बड़ हो जाती है तो वो सेल्स एक्टिवेट हो जाते हैं और वो सिग्नल्स भेजते हैं अपने ब्रेन को. ठीक है, सो इन दिस केस if there is a disturbance in the glomerular filtrate rate, if there is a disturbance in the glomerular filtrate rate, then they activate some specific cells called as the macula densa cells, and these macula densa cells, they detect changes in the rate of urine flow and the luminal sodium chloride concentration. The increase in urine flow rate and increase in the urine flow rate, it activate macula densa. It communicates with the granular cells and the vascular segment of the juxtaglomerular apparatus. After stimulation of this juxtaglomerular apparatus, it causes renin to be released. Once renin is released, it leads to the generation of the angiotensin II hormone. And once angiotensin II is generated, it causes the vascular constriction and lead to the decrease in the glomerular filtrate rate and the decrease in the effectiveness of the diuretics. Because what is the function of the diuretics? Diuretics are the agents which increase the urine flow rate, but if we want to inhibit the function of the diuretics, if we want the decrease in the effectiveness of the diuretics, then at that time this juxtaglomerular apparatus passes the signal, and after passing the signal they activate the angiotensin II. Once angiotensin II is get released, it produces the renal vasoconstriction. रेनल vasoconstriction हो गया, यानी उसका मतलब क्या कि जो भी ग्लोमेरुलर फिल्ट्रेट रेट है वो भी कम हो जाएगा. ठीक है. Then another important regulatory mechanism for urine formation is the ADH, that is the antidiuretic hormone. They are also known as the vasopressin. This antidiuretic hormone released from posterior pituitary in response to decrease in the blood pressure. Now in kidney, this antidiuretic hormone, also called as the vasopressin, they acts on the CD, they acts on the collecting tubule to increase water permeability and the reabsorption, and as a result urine become more concentrated and water is conserved in presence of the ADH, that is the antidiuretic hormone. Okay. Now next one is the disease state. Now how the diuretics are used, what is the significance of the diuretics? Now these diuretics drugs, they are used to treat the edema and the hypertension, right? These diuretics drugs, they are generally used to treat the edema and the hypertension. एडिमा म्हणजे काय, सूज येणे, त्याला काय म्हणतात आपण, एडिमा. So these drugs, they are used in the treatment of the edema and the hypertension. Now how the edema occur? The edema, it is a result from disease to the heart, kidney or the liver. Means हार्ट, किडनी किंवा लिव्हर इथे जर एडिमा झाला, एडिमा अशा ठिकाणी कसा होईल की when there is some damage takes place to the heart, kidney or liver, so after damage there is edema occur. So edema, it is results from disease to the heart, kidney or the liver. The decrease in cardiac function, that is for example congestive heart disease, it results in the decrease in perfusion of all organs, example kidney and limbs, and an accumulation of edema fluid in the extremities, that is around ankles and the hands. So after damage of the heart, kidney of liver, now they have given the example of the heart. So when the patient is suffering from some congestive heart diseases, then it results in the decreased in the perfusion of all organs. Okay, after the patient is suffering from some congestive heart diseases, then what will happen? Then it results in the decreased in the perfusion of all organs and limbs, and thereby accumulation of edema fluid is takes place in the extremities, that is around the ankles and the hands. If the left heart failure takes place, then it leads to the development of the acute pulmonary edema, and if the right heart failure takes place, then it shifts extracellular fluid volume from arterial to the venous circulation, which lead to the general edema formation. The kidney dysfunction lead to the edema formation, and as a result of decreased formation of urine and subsequent imbalance of the water and the electrolyte homeostasis takes place. Also, retention of salt and water result in the edema formation, because kidney is not working. If the kidney is not working, then whatever the salt and water which are generally excreted through the urine, so they are not excreted, so they just remain in our body, the salt and water. So what will happen? If they are remain in the body, then the person become fatty, the person become fatty, so the edema is formed, right? So in these some disease states, these diuretics drugs are used. Now there are various diuretics drugs. The diuretics drugs, they are used acutely or chronically to treat the edema, right? If we want the immediate action, then the intravenous loop diuretics are used. If there is a non-emergency case, then the thiazide or the loop diuretics are given by the oral route. Whatever the magnitude of the diuretic response, it is directly proportional to the amount of edema fluid present, right? जो भी अपना डायरेटिक है, वो डायरेटिक कितना रिस्पॉन्स देगा? जितना एडिमा फ्लूइड अपने बॉडी में प्रेजेंट रहेगा उतना. इफ डायरेटिक इंड्यूस्ड हाइपोकैलिमिया डेवलप, डायरेटिक देने के बाद अगर हाइपोकैलिमिया हो गया, हाइपोकैलिमिया मीन्स व्हाट, कि पोटेशियम कम हो गया अपने बॉडी में, तो उस टाइम पोटेशियम स्पेयरिंग डायरेटिक्स देते हैं, पोटेशियम स्पेयरिंग डायरेटिक्स. Then also thiazide or loop diuretics agents are given orally to control blood pressure in the hypertension. The diuretics are first drug to treat hypertension, and they are added to other drug therapies to control the blood pressure. The diuretics agents, they are also used by some athletics for the sport doping. This produces weight loss via excretion of water. Now we've seen now the Olympic Games are going on, but right now there are very strict rules. अगर आप लास्ट टाइम देखते हैं यानी कुछ सालों पहले जनरली ये जो भी एथलेटिक्स रहते हैं ये एथलेटिक्स क्या करते हैं डायरेटिक्स कंज्यूम करते हैं जस्ट उनका गेम स्टार्ट होने से पहले फॉर एग्जांपल रनिंग रेस रहती है 100 मीटर रनिंग एटसेट्रा एटसेट्रा बहुत सारे अभी ओलंपिक के गेम रहते हैं सो टू गेट इंस्टेंट एनर्जी ये जो भी लोग रहते हैं तो वो क्या करते हैं डायरेटिक्स कंज्यूम करते हैं उनका जो भी स्पेसिफिक कंपटीशन है वो कंपटीशन स्टार्ट होने के पहले डायरेटिक्स कंज्यूम करते हैं तो उससे इमीडिएट इफेक्ट मिलता है कैसे इमीडिएट इफेक्ट होता है कि वेट लॉस होता है बाय द एक्सक्रीशन ऑफ द वाटर वेट लॉस हो जाता है सो वेट लॉस होगा तो वो ज़्यादा तंदुरुस्त रहेंगे तो वो उनका जो भी गेम है वो ठीक तरह से रिजल्ट दे पाएंगे तो डोपिंग आपने पढ़ा होगा स्पोर्ट डोपिंग सो स्पोर्ट डोपिंग इज व्हाट दैट इज द कंजम्पशन ऑफ द डायरेटिक्स राइट अभी कौन से ऐसे डायरेटिक्स है विच आर यूज्ड इन द स्पोर्ट डोपिंग दैट इज अ फ्यूरेसेमाइड ट्रायमटेरिन and the hydrochlorothiazide furosemide triamterene and the hydrochlorothiazide so these are the agents they are commonly used for the sport doping as they rapidly eliminate from the body ठीक है ना ये जो भी एजेंट है फ्यूरेसेमाइड ट्रायमटेरिन एंड द हाइड्रोक्लोरोजाइड ये जो भी ड्रग है जो स्पोर्ट डोपिंग में यूज करते हैं तो वो रैपिडली एलिमिनेट भी हो जाते हैं तो वो अगर उनका कुछ टेस्ट किया बाद में तो वो डायरेक्ट का कुछ भी ट्रेसेस मिलते नहीं अपने बॉडी में ठीक है डायरेक्ट से कुछ भी ट्रेसेस मिलते ही नहीं है अपने बॉडी में राइट एंड हेंस दीज ड्रग्स आर यूज्ड इन द स्पोर्ट डोपिंग बट अभी तो रूल्स बहुत स्ट्रिक्ट हो चुके हैं ओलंपिक में अभी डोपिंग वगैरह कुछ दिखने को तो मिलता नहीं है स्पोर्ट डोपिंग बट पहले तो था
right so these diuretics they are further classified into the 5 different classes osmotics then carbonic anhydrase inhibitors thiazides and thiazide like diuretics loop or high ceiling diuretics and the last one is the potassium sparing diuretics these are the various site of action of all the diuretics the osmotic diuretics they act on the proximal tubule loop of Henle and the collecting tubule the carbonic anhydrase inhibitors they act on the proximal convoluted tubule that's the PCT thiazide diuretics they act on the cortical portion of the TALH and distal tubule whereas the loop or the high ceiling diuretics they act on the thick ascending limb of the loop of Henle that is the TLH and the potassium sparing diuretics they act on the distal tubule and the CD that is the collecting duct so these are the various site of action of all these diuretics so yesterday we have studied the structure of the nephrons and in that structure of the nephrons we have studied these various components of the nephrons that is the PCT, PST, then distal tubule, then collecting duct. So these all are the site of action. So yesterday I had discussed that जे पण आहेत these are the components of the nephrons. So all these components absorb the different ions and because of these all these components of the nephrons are the site of all the diuretic classes right so the mechanism of action is osmotic diuretics the osmotic diuretics which act on the proximal tubule loop of Henle and the collecting tubule their mechanism of action is those osmotics which act on the proximal tubule the mechanism of action of those diuretics is they decrease the sodium and water reabsorption by the osmotic effects. Those diuretics which act on the loop of Henle, they increase medullary blood flow. They increase the medullary blood flow to decrease medullary hypertonicity and reduce sodium and water reabsorption. The diuretics, the osmotic diuretics which act on the collecting tubule, they act by decreasing the sodium and water reabsorption because of reduced medullary hypertonicity and the elevated urinary flow rate. So the main objective of all these diuretics is what? That is to uh, increase the flow of these ions, specifically sodium and the chloride ion. And with this sodium and chloride ion, also to excrete the water from the body. So that is the main objective of these diuretics. If it is fail, if the diuretics fail to excrete the secretion of this ion, then what will happen? The edema will happen. Yesterday we have discussed about the disease states. So these diuretics are used in the treatment of the edema and the hypertension, right? Yesterday we have discussed about this. So if these ions, if they not secrete from the body, then what will happen? The edema, the person is suffering from the edema. Then the next class is the carbonic anhydrase inhibitors. And the mechanism of action is inhibition of the renal carbonic anhydrase enzyme, which decreases sodium bicarbonate reabsorption. So yesterday we have discussed about this carbonic anhydrase. So what is the role of the carbonic anhydrase enzyme? This enzyme, carbonic anhydrase enzyme, it uh, it synthesizes the carbonic acid. It synthesizes the carbonic acid from the carbon dioxide and the water, and that carbonic acid it donate the H plus ion. It donate the H plus ion, and it act as an exchange material. Means what? की सोडियम आयनला घेतं आणि हायड्रोजन देतं है ना. That is the function की whatever the carbonic acid is formed. So what that carbonic acid do? That carbonic acid donate the hydrogen and it accept the sodium ion. So what will happen? The sodium ions are get retained in our body. And what we want? That is we want to excrete this sodium and chloride ion. But what this carbonic acid do? The carbonic acid donate the hydrogen ion and it accept the sodium ion. That is the exchange program. So we have to inhibit this carbonic anhydrase enzyme. So if we inhibit the carbonic anhydrase enzyme, then the carbonic acid is not formed. Then the next one is the thiazide and the thiazide-like diuretics. They inhibit the sodium and the chloride symporter. The loop or high sealing diuretics, inhibition of the luminal sodium potassium chloride transport system. Then the potassium sparing diuretics, the mechanism is inhibition of sodium and water reabsorption by competitive inhibition of the aldosterone and blockage of the sodium channel at the luminal membrane. So these all are the mechanism of action in short mechanism of action of all these diuretics. So we will discuss this mechanism of action one by one in different classes. Okay, so the first class out of these 5 class is the carbonic anhydrase inhibitors. Now, carbonic anhydrase inhibitors, in 1937, it was proposed that normal acidification of urine was caused by secretion of hydrogen ion by the tubular cells of the kidney, and these ions were provided by the action of the enzyme carbonic anhydrase, which catalyzed the formation of carbonic acid from the carbon dioxide and water. So, what we have discussed, right? What we have discussed, that is the carbonic anhydrase enzyme catalyze the conversion of carbon dioxide and water into the carbonic acid, and that carbonic acid it what it donate the proton and make the urine acidic. It also was observed that sulfanilamide rendered the urine of dog alkaline. Sulfanilamide, it rendered the urine of dog alkaline because of the inhibition of the carbonic anhydrase. So they make some experiment, and in that experiment study, they found that the dog urine become alkaline by the inhibition of the enzyme carbonic anhydrase. So this inhibition of the carbonic anhydrase result in a lesser exchange of hydrogen ion for sodium ion in the kidney tubule. So after inhibition of the carbonic anhydrase enzyme, it was found that the exchange program is get reduced. That is, hydrogen ion is not exchanged with the sodium ion in the kidney tubule. The sodium ion along with bicarbonate ion and associated water molecule were then excreted, right? If the exchange program is not happen, then the sodium ion along with the bicarbonate ion and the water molecule, it is then get excreted and the diuretic effect was observed. The large doses required and the side effects of the sulfanilamide prompted a search for more effective carbonic anhydrase inhibitor as a diuretic drug. So, by use of the sulfanilamide agent, of course, sulfanilamide is a diuretic agent. It shows very good carbonic anhydrase inhibitory activity, but there are certain side effects of that drug. So, because of that side effect, the scientists modify the sulfanilamide agent. It was soon learned that sulfonamide portion of an active diuretic molecule, it could not be monosubstituted or the disubstituted. So they found an observation that the sulfonamide portion of the diuretic molecule, it should not be monosubstituted or disubstituted. It was a reason that more acidic sulfonamide bind more tightly to the carbonic anhydrase enzyme. So by this monosubstitution or the dissociation of the sulfonamide portion of the diuretic molecule, that sulfonamide molecule or that diuretic drug, it become the alkaline. But we want the sulfonamide acidic. If the sulfonamide is acidic, then it can bind tightly to the carbonic anhydrase enzyme. So the synthesis of more highly acidic sulfonamide produce compound with activities greater than 2500 fold that of the sulfanilamide. Yes. So what are the acidic sulfonamides? They later on synthesized by taking the sulfanilamide as a parent moiety. So that sulfonamide molecule, which is not monosubstituted or disubstituted because it is highly acidic. So that acidic sulfonamide shows 2500 fold more activity as compared to the parent sulfanilamide moiety. So the first sulfonamide was the acetazolamide, and it was introduced in year 1953 as an orally effective diuretic drug. Before the use of the acetazolamide, the organic mercurials which are commonly required intramuscular injection were the principal diuretics available. So before the use of the acetazolamide as a sulfonamide as a diuretic, the organic mercurials which are used for to show the diuretic effect, and these organic mercurials are given by the intramuscular injection. The carbonic anhydrase inhibitors, they induce diuresis by inhibiting the formation of the carbonic acid within proximal and distal tubular cells to limit the number of hydrogen ions available to promote sodium reabsorption. Of course, this drug do? That is, this drug inhibit the enzyme carbonic anhydrase and thereby the synthesis of carbonic acids get inhibited. So, at which site this drug act? So, this drug act on the proximal convoluted tubule and the distal tubular cells. For a diuretic response to be observed, more than 99% of the carbonic anhydrase must be inhibited. So, to get better diuretic response, about 99% of the carbonic anhydrase enzyme must be inhibited. Although carbonic anhydrase activity in the proximal tubule regulate the reabsorption of approximately 20% to 25% of the filter load of sodium. The carbonic anhydrase inhibitors are not highly efficacious diuretics. What it has mentioned, that is the carbonic anhydrase activity in the proximal tubule, it regulates the reabsorption of approximately 20 to 25% filter load of sodium. The carbonic anhydrase inhibitors are not highly efficacious diuretics. Yes. So what are the diuretics we have used as a carbonic anhydrase inhibitors? They show the effect as a diuretics, but it was found that in proximal tubule the reabsorption of 20 to 25% sodium is get reabsorbed by the use of the carbonic anhydrase inhibitors, and hence the carbonic anhydrase inhibitors, they are not highly effective diuretics. An increased excretion of only 2% to 5% of the filtered load of sodium is seen with the carbonic anhydrase inhibitor because of the increased reabsorption of sodium ion by the ascending limb of the loop of Henle and the more distal nephron segments. Yes, so there is only 2 to 5% of the sodium is get excreted by the use of the carbonic anhydrase inhibitors. Most of these sodium ions are get reabsorbed in the ascending limb of the loop of Henle and at the distal nephron segments. And because of this, only 2 to 5% only sodium is get excreted, and because of this reason, these carbonic anhydrase inhibitors are not effective diuretics.
सर
Yes.
या प्रिव्हियस स्लाइड मधले लास्टचे 2 पॉइंट शॉर्ट मध्ये एक्सप्लेन करा ना.
या स्लाइडचे या स्लाइडचे का
येस सर.
ओके. सो याच्यामध्ये त्यांनी काय सांगितलंय की इन शॉर्ट जर सांगायचं झालं तर जे कार्बोनिक अनहायड्रेस इनिबिटर्स आहेत, कार्बोनिक अनहायड्रेस इनिबिटरचं काम काय की सोडियम क्लोराईड आणि वॉटरचं एक्सक्रिशन करायचं. पण जनरली होतं कसं की जर का चांगली डायरेटिक इफेक्ट दाखवायचा असेल तर जनरली 99% कार्बोनिक अनहायड्रेस एन्झाईम इनिबिट व्हायला पाहिजे. अराउंड 99% कार्बोनिक अनहायड्रेस एन्झाईम इनिबिट व्हायला पाहिजे. ओके. बट व्हॉट ॲक्च्युली हॅपन की इथे यांनी म्हटलंय की अराउंड 20 to 25% सोडियम जे पण असतात त्यांचं रिॲब्झॉर्प्शन होतं. ठीक आहे ना. कार्बोनिक अनहायड्रेस इनिबिटर्स यूज केल्यानंतर पण अराउंड 20 to 25% सोडियमचं रिॲब्झॉर्प्शन होतं. कुठे होतं तर ते प्रॉक्झिमल ट्युब्युलमध्ये होतं. जे पण प्रॉक्झिमल ट्युब्युल्स असतात नेफ्रॉनचे आपण काल कॉम्पोनंट्स पाहिले, तर त्या नेफ्रॉनच्या कॉम्पोनंट्समध्ये ज्या प्रॉक्झिमल ट्युब्युल्स आहेत, तर बाय द यूज ऑफ द कार्बोनिक अनहायड्रेस इनिबिटर्स दे आर नॉट हायली इफेक्टिव्ह इन दिस प्रॉक्झिमल ट्युब्युल, and hence 20 to 25% of the filtered load of sodium is get reabsorbed in the proximal tubule, and hence these carbonic anhydrase inhibitors are not highly effective in the proximal tubule. And also it was observed that only 2 to 5% of the filtered load of sodium is get excreted with the urine with the by using the carbonic anhydrase inhibitors. Actually, if we are using the carbonic anhydrase inhibitors, then what we want, if we are using carbonic anhydrase inhibitors, then it inhibit around 99% of the carbonic anhydrase enzyme. It should inhibit the 99% of the carbonic anhydrase enzyme, but it failed to inhibit this enzyme. So what it was observed? That it was observed that only 2 to 5% of the filter load of sodium is get excreted with the urine, and hence these carbonic anhydrase inhibitors are not effective. Most probably, the reabsorption of these ions are takes place at the ascending limb of the loop of Henle and the distal nephron segment. Means what? की जे पण हे असेंडिंग लिंब ऑफ द लूप ऑफ हेनले आहे आणि डिस्टल नेफ्रॉन सेगमेंट आहे, तर तिथे सोडियमचं रिअब्झॉर्प्शन होतं. तिथे सोडियम आयनचं रिअब्झॉर्प्शन होतं. ॲक्च्युली रिअब्झॉर्प्शन व्हायला नाही पाहिजे बिकॉज दीज आर द कार्बोनिक अनहायड्रेस इनिबिटर, सो they have to inhibit the reabsorption of sodium. But these ascending limb of the loop of Henle and the distal nephron, they reabsorb the sodium, and only 2 to 5% of the sodium is get excreted with the urine, and hence these carbonic anhydrase inhibitors are not effective diuretic agents. So that is mentioned in this last paragraph.
ओके सर.
Regarding the structural activity relationship, the SR studies involve simple heterocyclic sulfonamide yield the prototypic carbonic anhydrase inhibitor, that is the acetazolamide. Okay, we will check out the structural activity relationship in the next slide. Okay, so just check out. This is the sulfanilamide moiety. It is visible to you. Then this is the sulfanilamide moiety, and from this sulfanilamide moiety, the heterocyclic sulfonamides are synthesized. The first heterocyclic sulfonamides which is synthesized from sulfanilamide is the acetazolamide, and the second one is the methazolamide. Okay, acetazolamide and the methazolamide. Then again from the sulfanilamide moiety, some metadisulfonyl benzenes are also get synthesized. the first metadisulfonamide benzene, which is synthesized from the sulfanilamide, is the dichlorphenamide, and the second one is the chloraminophenamide. Dichlorophenamide, and the second one is the chloraminophenamide. These are the structural activity relationship. Again, we will study these SR points in the next slide. So just keep in mind, these are the development of the two classes of the carbonic anhydrase inhibitor based on the action of the sulfanilamide. So by taking the sulfanilamide as a parent moiety, two classes are get synthesized. First one is the heterocyclic sulfonamides, and the another one is the meta-disulfamyl benzenes. Okay, so from sulfanilamide, acetazolamide and the methazolamide are get synthesized, and from sulfanilamide, meta-disulfamyl benzenes are get synthesized. So the example of meta-disulfamyl benzenes are dichlorphenamide and the chloraminophenamide. Okay, so this is the sulfanilamide. Sulfanilamide is primarily used in the treatment of the bacterial infections, and later on it was observed that it produces mild diuretic effect. How it shows the mild diuretic effect? Of course, by inhibiting the enzyme carbonic anhydrase. But it is a weak, it shows a very weak activity and having the severe side effects. So this is the structure of the sulfanilamide. So because of this weak activity and the severe side effects, they take this moiety as a parent moiety or as a pharmacophore, and from this pharmacophore they diuretize this sulfanilamide and synthesize various heterocyclic compounds as well as the meta-disulfamyl benzenes. So to improve the carbonic anhydrase inhibitory property of sulfanilamide, many sulfamyl containing compounds were synthesized and screened for their diuretic activity and ability to inhibit the carbonic anhydrase enzyme. So two groups, the first one is the heterocyclic sulfonamides and the second one is the meta-disulfamyl benzene derivatives. So from sulfanilamide, what we have discussed, that the first heterocyclic compound was synthesized is the acetazolamide, whereas the second compound which is synthesized, that is the methazolamide. Regarding the structural activity relationship, so this is the basic structure of our heterocyclic compound, that is the acetazolamide. So this is the structure of the acetazolamide. So the primary SR point is what? The sulfonyl group. This group, sulfonyl group, that is the SO2NH2. This sulfonyl group, it is essential to show the diuretic effect, right? If you want the diuretic activity of these heterocyclic sulfonamides, then in the heterocyclic sulfonamides, this sulfonyl group is mandatory. If it is absent, then it does not show the diuretic effect. Then the second point is the sulfonyl nitrogen atom. It must remain unsubstituted to retain the activity. If we substitute this nitrogen with the bulky alkyl groups, then the activity is get decreased or it get diminished. So this nitrogen should be unsubstituted to show the activity. Then the derivative with the highest lipid or water partition coefficient and the lowest pK have the greatest carbonic anhydrase inhibitory and the diuretic activity, right? So these are the SR points of the heterocyclic sulfonamides. Then okay, we will check out the structure of methazolamide in the next slide. Then this is the meta-disulfamyl benzene derivative. So the first meta-disulfamyl benzene is synthesized is the dichlorphenamide, and the second one is the chloraminophenamide, right? Acetazolamide is what? Acetazolamide and the methazolamide was the heterocyclic heterocyclic sulfonamides, whereas the dichlorphenamide and the chloraminophenamide, these are the meta-disulfamyl benzene derivative, which shows the diuretic effects. Regarding the SR point, this position, so at this position, sulfonyl, that is the SO2NH2 group should be present. Okay, so at this position, so if you check the structure of the dichlorphenamide and the chloraminophenamide, so at this position, the SO2NH2 group should be present and it should be unsubstituted. That sulfonyl group should be unsubstituted. Then again, if we want the maximum diuretic activity, then this position should be substituted with the chlorine or bromine or the CF3 or the NO2 group, right? Then the sulfonyl moiety at this position, it should be replaced with similarly electrophilic groups such as the carbonyl or the carbonyl group that may increase the diuretic potency while decreasing carbonic anhydrase inhibitory activity. Okay, so if we substitute this position by any of the electrophilic group like the carbonyl group or the carbonyl group, then it shows the diuretic potency, it shows the diuretic activity, but it decreases the carbonic anhydrase inhibitory activity. And the last point is substitution with an amino group increases celluritic but decreases carbonic anhydrase inhibitory activity. Now, what is the celluritic activity? That is the increased secretion of the salt. That is the NaCl. That is called as the celluritic activity. So if we substitute this group with a amino group, then it increases the celluritic activity. Means what? It increases the secretion of the salt, but it decreases the carbonic anhydrase in activity. Okay. So these two positions are very crucial. They show the diuretic activity at these two positions, but they decrease the carbonic anhydrase inhibitory activity. So at this position, what they do, that is, they will not inhibit the carbonic anhydrase enzyme, but they show the diuretic activity by some different mechanism of action. Okay. So these are the SAR of the metadisulfamylbenzene derivatives. Then the carbonic anhydrase inhibitors, they are given primarily to decrease intraocular pressure by decreasing the rate of aqueous humor formation to treat the glaucoma. So generally these carbonic anhydrase inhibitors, that is the acetazolamide, methazolamide and the dichlorphenamide, they are used in the treatment of the glaucoma. Regarding the therapeutic application, with the prolonged use of the carbonic anhydrase inhibitor diuretics, the urine become more alkaline and the blood become more acidic. If we use repeatedly this carbonic anhydrase inhibitor, so because of that urine become more alkaline and the blood become more acidic. So when acidosis occur, that is when the blood become more acid. So when acidosis occur, the carbonic anhydrase inhibitor lose their effectiveness as diuretics, right? So if we use repeatedly this carbonic anhydrase inhibitor, so this is a side effect that it does not show the diuretic activity because uh, because because the continuous use of these carbonic anhydrase inhibitors, the urine becomes alkaline and the blood becomes acidic. So when the blood becomes acidic, then that term is called as the acidosis. So in the acidosis condition, the carbonic anhydrase inhibitors, they lose their effectiveness as a diuretics. They remain ineffective until normal acid-base balance in the body has been regained. For this reason, the class of this compound is limited in its diuretic use. Today, they are most commonly used in the treatment of the glaucoma, in which they inhibit carbonic anhydrase enzyme in the eye, reduce the rate of aqueous humor formation, and consequently reduce intraocular pressure. This compound also found some limited use in the treatment of absence seizure, to alkalinize the urine, to treat familial periodic paralysis, to reduce metabolic alkalosis, and prophylactically to reduce acute mountain sickness. So these are the various therapeutic applications of the carbonic anhydrase inhibitors. And these are the drugs. So there are around 1, 2, 3, 4. Right? 4 drugs are there in our syllabus. The first drug is acetazolamide. Second one is the methazolamide. Then the next one is the ethoxyzolamide. And the last one is the brinzolamide. So these are the drugs which are there in our syllabus. So acetazolamide, which is a thiazole derivative, was the first of the carbonic anhydrase inhibitors to be introduced as an orally effective diuretic agent, with a therapeutic effect that lasts approximately 8 to 12 hours. So it's having a very long duration of action, that is around 8 to 12 hours. As mentioned earlier, its diuretic action is limited because of the systemic acidosis it produces. So what is the acidosis? That is, the blood become acidic and the urine become alkaline. So when the acidosis occur, so at that time, this diuretic agent does not show properly carbonic anhydrase inhibitory activity. Okay, so this is the structure of the acetazolamide. And if we check the structure of the acetazolamide, so here is the amide group. So this group is called as the acetamide, that is the CH3C-O-NH2. So we'll start the IPC nomenclature from this nitrogen, that is the N dash of the acetamide. So N dash, and the numbering of this ring, the name of the ring is the thiazole. So the numbering of the thiazole, it begins with the sulfur. So 1, 2, 3, 4, 5. So we have to count anti-clockwise, not clockwise, because we have started our IPC temperature from this position, from this nitrogen, and this nitrogen is at the left position of the sulfur. Hence, we have to count from the as the anti-clockwise. So 1, 2, 3, 4, 5. So this is the numbering of this thiazole. So N dash 5 sulfamyl. So this sulfamyl group is present at the fifth position. Hence N dash 5 sulfamyl, 1,3,4 thiazole, 2YL, and this portion is what? Acetamide. Right. So this is the structure of the acetazolamide, and this is its IPC nomenclature. Now the next one is the methazolamide and the ethoxyzolamide. Now this methazolamide is a close structural analog of the acetazolamide. If we check the structure, so there is only a little bit difference. There is the absence of this bond, and again there is the name is what? Methazolamide, means what? There is a methyl group additionally attached to the acetazolamide. So methyl group is attached at this nitrogen, and there is a double bond over here. So the structure methazolamide and the acetazolamide look alike, only there are minor differences. So methazolamide is a close structural analog of the acetazolamide, in which one of the active hydrogen in the thiazole ring has been replaced by a methyl group. This decreases polarity of the compound and permits a greater penetration into the ocular fluid, where it acts as a carbonic anhydrase inhibitor, reducing intraocular pressure. So as we have discussed, this diuretic agent, they primarily that is the carbonic anhydrase inhibitors. Now we are talking about the carbonic anhydrase inhibitors. So specifically these carbonic anhydrase inhibitors which act as a diuretics. So specifically these drugs are used in the treatment of the glaucoma, right? Just we have discussed. So these agents, the carbonic anhydrase inhibitors, which act as a diuretic, they used in the treatment of the glaucoma. So because of this addition of the methyl group, this methazolamide decreases the polarity and it permits greater penetration into the ocular fluid, where it acts as a carbonic anhydrase inhibitor, reducing the intraocular pressure. Its dose for glaucoma is 50 to 100 milligram 2 to 3 times a day. Ethoxyzolamide has a sulfonamide group. So this is the structure of the ethoxyzolamide. It is little bit different if we compare this drug with the acetazolamide and the methazolamide. So this ethoxyzolamide has a sulfonamide group attached to a fused 1,3-benzothiazole ring. Yes. So initially in acetazolamide and the methazolamide there was a thiazole ring. In the ethoxyzolamide there is a 1,3-benzothiazole. Only a benzene ring is get fused with the thiazole ring. So it becomes 1,3-benzothiazole. Typical doses are 62.5 to 125 mg up to 4 times a day. Distribution of these three drugs, that is acetazolamide, methazolamide, and the ethoxyzolamide, into ocular compartment is not selective, and they can also inhibit multiple carbonic anhydrase isozymes in other tissues because they are not selective, so they can inhibit other carbonic anhydrase enzymes which are present in the other tissues also. Regarding the IPC nomenclature of the methazolamide, so the IPC nomenclature is same as acetazolamide, little bit difference. Again, we start from the nitrogen atom of the acetamide, so N dash, then 3 methyl, N dash, then 3 methyl, then 5 sulfamyl. Now, always remember one thing, that while nominating IPC nomenclature, you have to follow always alphabetical order. Now, if you say, sir, we start from the sulfamyl, so it is not acceptable, because in the structure of the acetazolamide, there is no any other substituent present. Hence, we started from the sulfamyl, but in the methazolamide structure, there is a methyl group attached. So, M comes first as compared to the S. So, hence we started from the methyl group. So, the IPC nomenclature is what? That is the N dash, then 3 methyl 5 sulfamyl 2,3 dihydro. Why 2,3 dihydro? Because there is absence of the double bond in position in between carbon number 2 and 3. So 2,3 dihydro, 1,3,4 thiazole, 2-vilidin. 2-vilidin. What is the meaning of 2-vilidin? That is a alkylidin. 2-yl. 2-yl means what? That is a alkyl. But here is what? It is a alkyl. There is a double bond. Hence, at that time we call it as a 2-vilidin. Okay, understand these two things. 2-yl means what? There is only a single bond, and to this single bond there is a substituents are get attached. Hence, at that time we call it as a 2-yl. But if there is a double bond, then at that time we cannot say it is 2-yl. So at that time we can say it is 2-vilidin, because there is a double bond, alkylidin, alkylidin. Okay, so it is 2-vilidin. So keep in mind these things, these minor things. Okay, so 2-vilidin, and the remaining portion, that is the acetamide. Okay, so this is all about the methazolamide. Regarding the IPC nomenclature of the ethoxylamide, so here it is mentioned. So we started from the 6 ethoxy. So we started the numbering of the 1,3-benzothiazole from the sulfur group. So what is the name of this ring? That is the 1,3-benzothiazole. So we start, because there is no any amide group in the previous structure, in the acetazolamide and the methazolamide. We started from the N dash of the acetamide. Now here, if you check, there is no any amide group. So we started the IPC nomenclature from the sulfur. Okay, we started the numbering from the sulfur. So 1, 2, 3, 4, 5, 6. So it is 6 ethoxy, 1,3-benzothiazole, 2 sulfonamide. Yeah, in this case, amide is present over here. In the previous structure, we count it as a sulfamyl group. In the previous structure, we count it as a sulfamyl group, because we consider this acetamide group, this amide group. Now here, again we given the priority to the amide. So here the amide is a sulfonamide. Okay, the amide is a sulfonamide. So this is the IPC nomenclature of the ethoxylamide. Then the next one is the brinzolamide. Now this brinzolamide, it contain, now this is the structure of the brinzolamide. So check out properly. The IUPAC nomenclature is get fused with the structure. Okay, so check out properly the structure. So the brinzolamide, it contain ionizable amino groups. It contain the ionizable amino groups, and are the result of efforts to develop water soluble carbonic anhydrase inhibitor that remain sufficient lipophilicity to penetrate the cornea. They are only indicated for topical eye administration in glaucoma patients. However, both drugs can be absorbed from ocular fluids into the blood. So both drugs, so we can skip the both drug, because there is only one drug in this case, that is the brinzolamide. So this drug can be absorbed from ocular fluid into the blood. This result in prolonged half-life, because the drug bind to the carbonic anhydrase, especially in the red blood cells. Regarding the IPC nomenclature, the IPC nomenclature of the brinzolamide, again in this case we count it as a sulfonamide, because there is no any acetamide. This is not acetamide, right? This is not acetamide, so this is the sulfonamide. Okay, so we will start our IPC nomenclature from by given numbering from the sulfur. Okay, so 1, 2, 3, 4, 5, 6, and 7. Okay, so by alphabetical order, there is a ethyl group which is present over here. So we'll start the IUPAC nomenclature from the 4th position of this ring. So 4 dash ethyl amino, 2 dash 3 methoxy. Now there are 3 carbons in a straight chain. See, CH2 3. So there are 3 carbons in a straight chain. So 1, 2, 3. So 3 position पे क्या है? Methoxy. So after 2 dash 3 methoxy propyl, 1 dioxo, 1 dioxo, 3 4 dihydro. Why we mention 3 4 dihydro? Because there was a double bond in the thiazine ring. In the thiazine ring. Hence, there is no any double bond. So we can count it as a 3 4 dihydro. Thieno, thieno, thiazine. So this one thieno, thiazine. 6 sulfonamide. 6 sulfonamide. So this is the IUPAC nomenclature of our last drug, that is the brinzolamide. And this is what all about the carbonic anhydrase inhibitors. Okay, this is what all about the carbonic anhydrase inhibitors.